should get started here. We want to make best use of your time and everybody else's here. So thanks so much for coming. This is our second virtual First Friday Forum, and pleased to have Dr. Michael Ripchinski from Lancaster General with us today. And we'd like to thank our sponsors, Rogers & Associates. They've been a loyal sponsor of this event. We're very appreciative of them for that, as well as Millersville University. We usually are at the Ware Center, but today we'll just pretend that we're there. So thanks to those sponsors. We appreciate your support as always. We'd like to just talk a little bit about what the functionality of this presentation will look like today. On the bottom of your screen, there are a Q&A function. If you see it on the bottom there, and if you click there, you should be able to answer and submit a question. We will answer all these questions at the end of the presentation. And if you submit a question, you have the opportunity to see what other people submit as well, and then like their questions. There's a little thumbs up that you can click, and then the questions with the most thumbs up are the ones that we'll prioritize as asking to Dr. Ripchinski here. So make sure to use that functionality. This forum will be recorded and will be put onto YouTube afterwards. So make sure to check that out and feel free to share it. And we'll try to get the best use out of our time here with Dr. Ripchinski. Thanks so much for joining us.
Sure, thanks for having me. Looking forward to going through it and hearing everybody's questions.
Excellent, great. And so the Hourglass board submitted some questions to Dr. Ripchinski beforehand, items that we think, maybe other folks might have. This conversation came out of the idea that there's a bunch of information out there. Not all of it is accurate and on what this virus is, some basic information. And we thought, who best to talk about this than Dr. Ripchinski? So I'll let you take it away.
Okay, well, let me share the slides to start, and then should be good to go here.
Perfect.
There we go. So good afternoon, everybody. And I have maybe, 20 some slides or so we'll go through. And I think we're going to be able to answer a majority of the questions. Certainly heard a lot of them in the course of the pandemic. And hopefully this will give you an idea of where we are with tracing and testing, and sort of also start a little bit with the county level data. So sorry, I'm also realizing I'm going to be looking a little bit to my other monitor here while we do slides, but I'll try to also look at you guys as well. So we're going to start with the clinical overview today. And one of the first things we've really got into to talk about is the difference between COVID-19 and SARS-CoV-2. So the actual name of the virus is SARS-CoV-2, and you can see the disease is COVID-19. And there's 4 different strains of coronavirus that circulate seasonally, and it's our 3rd coronavirus outbreak this century, actually. Many of you know now about SARS-CoV-1, which most people just call SARS, and then you have MERS in 2012. There's been some debate about where did SARS-CoV-2, right, COVID-19 start, and there was a Newsweek article actually just in the last week or so that there was some concern, did it emerge from the seafood market in Wuhan or not, but potentially did it come out earlier in November or even potentially September, and it's unclear whether we'll know the exact location or animal or and where the virus came from. The other thing that I want to make mention sort of early on while we kick it off here is there's these 4 separate lines of evidence that suggest that U.S. Community transmission began that late January, early February. And then it was probably after one person from China followed by multiple others from Europe. And that's in a CDC publication also that was in May, in the end of May. So let me give you a couple things about what do we know so far. You can see most of you, I think, probably know virus is spread by close contacts, droplets, or aerosols now. That's why it's critically important that we wear masks to protect ourselves and others. What we call the household contact rate, I think, is what I really want to reiterate there. Early on, we saw in March that a potentially 10% risk for household members of getting COVID-19 if they have a positive case, if you will, in the house. There's a lot of discussion about risk factors for severe disease. and then putting you more at risk for COVID-19 and other underlying illnesses. I also included the case fatality rates in China, as well as South Korea here at the bottom of this second slide. But most what everyone wants to talk about is the sort of comparison of fatality rate, which is on this graph, essentially in the y-axis against the x-axis on the bottom of the average number of people infected by each sick person. And so you can see common cold here at the bottom, as well as the seasonal flu, which has a slightly higher fatality rate. And you can see the box from this New York Times article showing coronavirus ultimately appearing somewhere of a fatality rate below 3%. And the critical piece, and you've heard this now many times, is that one person with coronavirus can infect 2 to 3 people versus the flu virus, which one person can infect one other person. And so that increased transmission rate or high infectivity rate really makes coronavirus different than the flu. Let's talk a little bit about its clinical course. So right now, what we call the incubation period, which is the medical term for essentially how long could it be before symptoms, it generally has a 4 to 5 day range. Typically what we've been saying is, within the first 2 days you may have no symptoms, but by that second day, you certainly could develop them, and somewhere, certainly by the 11th day, mostly people have experienced some level of symptoms. And you can see those symptoms in the middle of this slide, still very common with fever, cough, fatigue, muscle ache, shortness of breath. Those are very common things when we screen patients, both at our community testing centers and in our practices. It's this list of symptoms are what we typically use to ask patients questions and queries about, how are you feeling prior to getting them tested. And at the bottom, there's a lot of conversation still in the community about, well, what's the frequency of time or the prevalence that asymptomatic infection is out there, or how often can we understand pre-symptomatic infection in that 0 to 2 day range. We don't have a lot of information on that yet. We have estimations on asymptomatic spread. I can tell you right now in our pre-procedural testing that we're doing with LGH, we're at about a 1% positive rate. So of the 2,300 or so patients that we've tested so far, only 22 have been positive. So the question is that asymptomatic positive, or will they have developed symptoms in the subsequent days? And we just happen to get them at the early part of their illness. But that 1% asymptomatic, pre-symptomatic infection rate seems to exist now, at least in Lancaster County. Others have shown some lower percents across all of the whole state. I know UPMC's published some rates as low as a 1/4 to 0.5% around their asymptomatic rates. Next slide's really about the continuing clinical course. We talk about how can we reduce the spread to others, right? It's critical now, no matter what color we are in for any county across the state of Pennsylvania, we have to help reduce the spread to others. And it's important to kind of know, how do we do that? If you end up having COVID-19, what this slide is basically saying at the top is you should really isolate yourself by using the following rules. You'd want to stay isolated from others for at least 3 days, since you want to have at least 3 days passing for recovery, and that's defined by the resolution of fever and not using any Tylenol to reduce that fever, as well as improvement in your respiratory symptoms, cough, shortness of breath. And then the other thing, the most important part, and you've at least had 10 days passed since your symptoms first appeared. So if you test positive, these are right off the CDC website. I gave you the link at the bottom of this slide. These are the kind of things, instructions you're going to get from both our contact tracing team and our nurse case investigators who may call you if you do turn positive. The second point I want to make here, there are no data concerning the possibility of reinfection. There's a lot of discussion and concern and questions about, well, what happens if I get reinfected? What do I do? How do I do it? You can see here that this possibility of reinfection still needs to be studied. And what's more compounding is this final point on the slide is this viral RNA that we're testing for with these PCR tests, which we're going to talk about in a little bit. viral shedding declines as your symptoms get better. But the issue is you may still be shedding virus for several days to weeks after those symptoms have resolved. And why is that important? It's important because of what I would call if you were looking to do a test-based strategy to go back to work, and the CDC talks about this kind of strategy. You may have no symptoms, and we don't know if you are still infected basically, and you could get a second COVID-19 test, which may still be positive, but your symptoms are no longer there. So that test is so sensitive, the PCR test, that may be picking up, if you will, like dead viral particles, which may still be circulating. But the question is, are you still infective or not? And it's much better to kind of try to follow what we call a symptom-based strategy to return to work or to come out of isolation like we have on the top of the slide because of the sensitivity of that PCR test. I thought I would cover a little bit of some of the therapeutic options and therapies we have. While none of them are FDA approved, I get a lot of questions in the community about therapies. Where are we with therapies? What are the best therapies right now? The best therapies, remember, are still symptomatic therapies because 80 to 85% of patients who get COVID-19 are going to get better. They're going to have mild symptoms. And those mild symptoms are treated just like you would treat the flu. And supportive care at home, hydration, rest, Tylenol to essentially keep your fever down. But if you do get hospitalized, we have a couple of hospitalization-like treatments that we can essentially put forward. And one is around high-flow nasal cannula. So you've been seeing the effect of using high-flow nasal cannula versus ventilated patients. And by that, I mean there are certain patients who may be, how shall I say, right now, we're trying to decrease the use of ventilation in those patients. And we use a technique called high-flow nasal cannula to do that. We've been able to decrease the ventilation of patients from about 25% of those who we see in the hospital down to about 10 to 15%. So that waiting, if you will, to hold off ventilation has really been helpful in people recovering. Plaquenil, while initially in favor as a potential early treatment, now has really been limited use and limited to clinical trials. Remdesivir, many of you have heard about from Dr. Fauci and others that really ended that clinical study from the NIH early, primarily because remdesivir was statistically, showing a statistical difference in total illness duration, so down from 15 days to 11 days, so reducing the total duration by 4 days. And there was a mortality reduction in that study as well. It was not statistically significant, but fairly close. So from a 12 to a 7% reduction there. So you can see remdesivir has certainly been one of our biggest, strongest tools to date. And we have adequate supply right now at LGH. And ironically, and that's why I like to talk about remdesivir a little bit. Ironically, the original allotments from the federal government on remdesivir were based on how many ventilated patients you had. So as LGH actually reduced the number of patients that were on the ventilator, it actually put us a difficult position because we didn't get as much remdesivir as others because we were able to change clinical care so quickly and able to care for patients without ventilating them. Tocilizumab is we call it an interleukin-6 inhibitor, and it essentially helps with the second week of patients who get ill with COVID-19. They have a high inflammatory response, and this IL-6 inhibitor is able to sort of cut down on that overall inflammation because the body's immune system is really starting to attack, if you will, the COVID virus. And as a result of that immune upregulation, we can use tocilizumab to kind of quell that storm, if you will. Convalescent plasma has certainly been in the news. We're now 37 patients as of yesterday transfused. We have 9 units available. Really appreciate the community's outreach for those that have had COVID-19 and have recovered. And we used about 30 days after recovery to then become a plasma donor. It's really been helping the patients that we've been giving plasma to because we've seen them defervesce or their fever really reduce quite quickly after giving the plasma. So we continue to submit data to the Mayo Clinic for this large-scale national trial for COVID, for convalescent plasma. Vaccination, a lot of questions about that. We're certainly a far way off. The news media wants it to be even sooner than in reality may be, because even if we scientifically have shown an effective vaccine, we still have manufacture, delivery, distribution to take care of, and none of those steps will occur quickly. I put some data on here, cited the CDC and a USA Today story, a quote on the right-hand side there, but you can see the CDC Advisory Committee on Immunization Practices will drive the ultimate recommendations of who gets it first and how does that happen. That's based on history, not necessarily for COVID-19, but wanted to kind of give you the background. That's how it typically is done. We will see if there's another methodology for that as we move forward. And then pieces at the bottom around herd immunity there, as when enough people in the population have been infected and developed that immunity to the virus, and the scientists' models estimate about 2/3 of the population, 2 out of 3, needs to be immune to establish that herd immunity and eventually stop the disease. So a long way to go, and to that end, we certainly need those infection control measures like social distancing, masking, as well as washing your hands to continue to prevent the spread until we have that vaccination and herd immunity. So let's get into a little bit of the data. These were from Wednesday this week, just so I could get the slides prepared, but we've been hanging out even as of yesterday at noontime, a 15% positive rate for all of Pennsylvania, and about 3.8% of the total state has been tested so far. At the bottom of the slide, you can see the age ranges. We get a lot of demographic questions about, what are the age ranges of those that are positive or negative, and you can get a sense for that across the state here from the Department of Health website, which I also put at the bottom for you to reference later as the data change every day. And we also on the right there have the hospitalization rates, so you can get a sense for most of the time we're seeing hospitalization rates, basically 57–60% of those over 65, as you can see at the bottom. Now, this is a slide that we started to create, I would say, in the last couple of weeks, using that publicly available data from the Department of Health. What we've done is tried to take a look at the percent positive testing for all of Lancaster County based on the result data that the Department of Health gives out every day. At the, just to give you a sense of the bars, we have a teal-colored new county cases appearing sort of at the very bottom of the slide, and the bluish color are the county negatives. And the yellow line here is the 7-day average positivity rates. So you can see lots of fluctuation from day to day. I get asked a lot about why the fluctuations from day to day, and it's a couple reasons why. One, well, we've started to increase testing, right? As a county, we're increasing testing. In fact, a couple days ago, we almost hit 500 tests done in one day at LG Health. And if you added the whole county that day, I'm sure we will well over 500. The other piece that's been happening, we've been starting to test congregate settings, right? The nursing home efforts, skilled nursing facilities, group homes, Amish communities, certain areas have been begun to get tested. And those results are kind of coming in buckets, if you will. So they kind of test a large group of people, 100, 200, 300 people. There's going to be a group of positives in there. They're going to get, if you will, bolus reported to the Department of Health. The same thing happens when Quest, who does a lot of our testing in the state, and obviously in Lancaster County, if Quest gives a whole bolus of results from the day before, that get completed with their testing cycles, you might see some days that are 30, but then the next day, Quest may play catch up and we might have 45 positive cases in that day. So that day-to-day fluctuation, there's a couple reasons for that. And in our partnership with the Department of Health now, we've been able to really kind of learn and understand a little bit more of what's happening on a day-to-day basis. So because of those day-to-day fluctuations, that's why the yellow line is very important there, because it's giving a 7-day moving average of percent positive rates. And so that scale, if you will, is on the right-hand side of the slide. And you can see, if you could see my mouse, we've been looking at around 13% or so. And on June 1st, we dropped a little bit sub 12%. The World Health Organization would actually say we should be in a range of about 10 to 12% positivity rate. And if we are in that range, then essentially we're effectively testing enough people. There's been a question early on of what's the right amount of tests? How do we know we're testing the right amount of people? And the World Health Organization would typically quote about a 10 to 12% positivity rate would indicate that. Now, early on in the pandemic, and you can see from this line, even in late April, we were over 20% positivity rates. And clearly we had an opportunity there to both increase testing as well at that time. So we'll continue to follow this line. I think it's an important indicator of where we are and the stability of those infection control measures across the county as we begin to reopen businesses. I always like to include some inpatient statistics. Many people ask about LGH, and for the most part, I think I haven't done the math in a little while, but we've been running around between 80 and 85% of the total inpatients in the county with COVID-19. Right now, this morning, we were about 45, and actually this slide was from the 4th, but as of early this morning, we had 13 in the ICU, 8 on ventilators. You can see our discharge number there. We're approaching 300 discharged, about a 7-day average length of stay, almost 8, and 2/3 of those that were ventilated now have been discharged alive. So a lot of work with our teams around improving the course for those patients that get ventilated. And we've had 78 deaths so far within the hospital, which is about about a quarter of the total deaths in the county. I think we're just over 300 now. 80% of the deaths have been admitted from skilled nursing facilities, and 2/3 of them have been do not resuscitate. So do not resuscitate order, wish from their own living will or their physician order for life-sustaining treatment that they give us at admission. And demographic-wise, early on, we actually had more females in the first couple of weeks, and now we pretty much are reflecting national data where we're about 85% male with an average age at 77. So I'll spend about 3 or 4 slides talking about what has LG Health done to mitigate COVID-19 across our health system. We initially structured our response to COVID-19 primarily around the CDC guidance as shown on this slide. And it's in 3 buckets. 1, limiting the people entering the system. 2, limiting exposures once you're into the healthcare system. And 3, really trying to figure out how to manage resources in the best way possible. So let me talk a little bit about those. 1, limiting people entering the system. Well, we've had a workforce transition occur, as many businesses have, to over 1,200 employees now working at home, and being able to telecommute, if you will, and remotely work has been a huge advantage to us and them. It's been able to allow them to stay at home, if you will, and continue to be productive. We also initiated some self-quarantine for business-related travel, and we told the workforce that obviously now is not the right time to travel, as many did. On the patient side of limiting those, about 80 to 85% can be managed at home. We talked about that a little bit earlier. We've initiated some phone screening for symptoms prior to appointments. Do you have a fever? Do you have shortness of breath? Prior to those appointments, we put up the community testing centers and tents at the Clipper Magazine and PA College. We've also screened patients who entered the buildings, screening for symptoms, temperature, fever. The visitation policy, while can be difficult for families, to be frank. We've certainly heard a lot of the stories and concerns from members in the community. We think it's of absolute importance to us to try to maintain a sense of security and safety for all of our patients. And so we put some visitation policies into effect as well. And many of you know we stopped urgent and emergent procedures in mid-March. That subsequently, by the way, reduced all of these actions, actually reduced our overall inpatient census to below 50% of what it typically is in the hospital setting. The second piece is around limiting exposures once in the system. And, we're certainly ready and able to care for you. We're beginning to put those safety measure communications out there. Many of you have seen those communications. These are the highlights from the bullets of the work we've been doing. Face masks required for all the patients and visitors over the age of 2. We are following the CDC guidelines to those instructions. We're doing a lot of deep cleaning in our clinical areas and frequent cleaning during the day. For those spaces, we've done a lot of work around waiting rooms and reconfiguration of spaces to ensure social distancing. We also have symptom screening, as I mentioned earlier, and that continues at all of our sites. And the other question I typically get is what's happening inside the hospital itself. We continue to dedicate COVID-19 units on 2 of our main units, and we actually have a 3rd unit for those that may be waiting for a bed to be discharged to a skilled nursing facility. So we actually have 3 units if you include critical care as well. So that gets us to 4 different areas where we can essentially cohort COVID-19 patients together. Big piece around limiting exposure continues to be masking and social distancing. We really want to make sure we reiterate the fact that wearing a surgical mask really protects others from your symptoms. So if you have cough and essentially sneezing or any symptoms that can be blocked by your mask, you're protecting others by wearing that mask. And you want to make sure it's fully covering the mouth and the nose. I've seen a lot of patients. I've started seeing patients scan water. I'm in Quarryville, and sometimes they're coming in and then their nose is out, or their cloth mask isn't fully covering. And I do advise them that it's not really going to work if there's large gaps or it's not covering their whole respiratory tract, nose, and mouth. We want to think about social distancing. It's critical even when you're wearing a mask, right? Because all of these factors are working together. We're trying to keep the hands clean, use the mask, and social distance. All 3 are very effective at trying to reduce the spread. And finally, one of the other big pieces that we've worked on in terms of mitigation for COVID-19 is really thinking about our supply chain and our resources. We talked a little bit about the medical supplies early on and those medications, while we were learning at the same time about what is the best treatments, as we talked about earlier for COVID-19. We also had to figure out how to get those supplies. And of course, some of them went to federal allotments, if you will, like remdesivir. But there are other things that we needed in terms of testing supplies, swabs. Certainly ventilators early on were a concern based on what we were seeing in New York City. And we certainly made some efforts across all of Penn Medicine to accumulate ventilators. But luckily we got to the point where both the clinical care had changed as well as those stay-at-home orders and mitigation efforts really worked. So we didn't have the spike in need that we're seeing in other cities and areas of the country, Washington State or New York City. Pharmaceutical supplies I talked about, but also I put community donations on this slide because I thought it was a great opportunity to thank all of you if you were involved in the efforts to supply donations to any of the healthcare systems in the county. Huge effort was undertaken to create masks. We've had thousands of masks been donated to us, and we have those cloth masks now able to use them if we need to for those visitors that may not have them, as well as potential backup in the future if we were to get a surge or spike. So appreciate all the efforts around that donation work. So let's get into testing and tracing a little bit. On testing, I mentioned earlier the PCR. Many people may not know what that stands for. It's the polymerase chain reaction test. And I gave a little graphic here from the Wall Street Journal and U.S. Department of Health and Human Services. Sort of gives you an example. If you didn't have the honor of having a nasal swab placed in your nasal pharynx or in your nose, you kind of get the idea. If you haven't seen it on in pictures or online, this gives you an idea of what happens here on the right-hand side of the slide. And then that sample essentially goes in, it's mixed with chemical reagents and put into this PCR machine to essentially duplicate the RNA. So we can detect very small amounts of RNA through this amplification process. And it allows us to have a very sensitive test that can really pick up even the minuscule amounts of viral RNA. So that's a good thing. Our turnaround times, we have had some questions on that. There are tests that we are able to use with PCR tests at LGH. And when you come to the hospital, it's best for us to know, because we're trying to practice those mitigation strategies I just went through. It's very useful for us to know if you have symptoms that are potentially COVID, like we talked about earlier. We want to know if you're COVID positive or negative so that we can assign you, if you will, to one of those units. So we use the rapid turnaround tests. We actually purposely keep them for those kind of hospital-based uses. We do not typically use the 45-minute turnaround test for routine screening just because there's still limited supply of those from a company called Cepheid that we get them from and a lot of the nation, that 45-minute turnaround test. So for a majority of our testing, in the community setting, we are using Quest, and we've seen turnaround times initially go 12 to 14 days in the early weeks as they were building their capacity to actually down to sub 2 days in most cases. We had a little bit of a spike a couple weeks ago where they were back to 3 to 5 days, but they increased their capacity in Chantilly, Virginia, where they are. And we only have about, out of 16,000 tests so far, less than 200 are pending when I looked this morning. So we're back down in turnaround times, and they've been a great partner for us and the county for sure. Now, there are some questions about antibody testing. I get a fair amount of those, as you can imagine. And the one take home I'll give you on the antibody testing is they really should not be used for the management of individuals. So for someone to run out to CVS and get an antibody testing, or run out to any lab and send it away, it's not that they necessarily have bad tests. It's just at the point now we don't have enough science to know what does that antibody test mean. And in a lot of cases, having antibodies doesn't rule out active infection, sort of the second to last bullet on this slide. So what we end up having to face is the conundrum of, okay, you have antibody tests. Could you be pre-symptomatic and you're about to get sick, or are you asymptomatic and you're carrying it, or you had it? And it's hard to know. So in a lot of those cases, we end up doing a PCR test to kind of understand, do you have active infection or not? But at this point, with the sensitivity and specificity of these tests being under question, there were a lot of manufacturers that rushed these antibody tests to market without the rigor of science and clinical trials to know how will they perform. That makes a lot of them suspect. And then to compound matters, if you use a test like this in a population that's asymptomatic, as I said earlier, if you don't have symptoms, it's really hard to predict whether or not you had a true positive or a potential false positive in this test. And that way, you don't really know. The other thing that makes the antibody testing difficult for us from the clinical side of this work is, well, what did those antibodies mean? I told you we don't know enough about reinfection yet. We don't know how long those antibodies will last. And we don't want to give someone a false sense of security that they can kind of go back to work and not wear a mask or not wash their hands just because they have antibodies. We don't know what that means yet, and it's difficult for us to provide that advice. Let's talk a little bit about the testing strategy, how to test, who to test, when to test. On the left-hand side of this slide, obviously, if you have two of those symptoms that I mentioned above, fever, myalgias, fever, shortness of breath, you're going to be tested. That's probably the clearest way to explain it. If you have a positive contact in one of those symptoms, you will also probably most likely get tested, and we're trying to consistently follow those guidelines. Now, on the right-hand side of the slide, we talk about people without symptoms. And I already alluded to one area, and many of you have heard about this, really throughout the nation, including the Lancaster County, is trying to test those who live and work in high-risk settings. So you think about a nursing home, a group home, a personal care home, any congregate setting where it's difficult to isolate positive cases from others. At a minimum, we would quarantine people who may have been exposed in those high-risk settings, but we may also consider doing widespread testing like we're doing in the nursing homes. And the final piece is, if you don't really work in any of these high-risk settings, it makes no sense to test you without symptoms at this point. Doing broad-scale asymptomatic testing, I already told you, is turning up less than 1% positives. So doing that at a wide scale doesn't make a whole lot of sense yet. The other thing that makes that a little confusing is, well, how often would you do it? There have been some concern of, well, we should test every single employee before they go back to work. Well, what happens in 2 days from now when some of them develop symptoms? Are you going to test them again? And then what happens 2 days after that? Are you going to test them again? It's really not a sustainable process, and certainly not a CDC recommendation at this time. Let's talk about contact tracing. A couple things on contact tracing. One of the biggest things without an effective treatment or vaccine, as we talked about earlier, you have to continue to identify and isolate new cases. So cases would be my term from the rest of this presentation for those that actually have a positive test. And a contact is someone who was around within 6 feet for more than 10 minutes around that positive case. So they were contacting or exposed, if you will, to a positive case. So we want to be able to identify both the cases as quickly as we can so that we can get the contacts so that we can communicate with the contacts. Like that's the biggest piece of the puzzle here. And ideally, we want to do this within 24 hours or less, because the longer it takes us to get to those contacts and cases, the harder it will be to really control the pandemic and really prevent the spread. So here's a little bit of the basic plan. You can see this slide's really talking about, we initially interview the patients with COVID-19 to identify their contacts. We have RNs on our teams that do that. We want to notify their contacts as quickly as possible about their exposure. Those contacts do not get to know who they were exposed to. There's sort of a separation of data there. So the contacts just know that they were exposed, and they're given instructions on how not to interact with others, how to quarantine themselves for a period of time based on that exposure time. And then we also want to monitor cases for symptoms, both the cases and the contacts, because think about it this way, a case who may be positive today, 3, 4, 7, 11 days from now, when they get into the second week of illness, they may require hospitalization. So it's very important for our team to continue to follow those original positive cases, but it's equally as important to follow the contacts, because if the contacts develop symptoms, they may need a test. And if they turn positive, we need to do it all over again and find their contacts as well. Meanwhile, all this time, both the cases and the contacts may have what we call social needs. They may have difficulties with financial situations, transportation, meals, food insecurity, housing insecurity. They may not be able to, isolate themselves. So trying to create connections for our community members who are both positive for COVID-19 and who are contacts, we want to create connections to them to social services in the county if they are needed. So we're doing that work as well. This gives a little schematic of essentially how we are going about doing that notification. To reiterate, the RN case investigators interviewing exposed individuals, they essentially give them instructions that you were exposed. And ideally, we want to follow up with you through a system we call SAR Alert, which is a system used to make text messages or phone calls or emails out to people to basically say, do you have any symptoms? And we want to check with you every day for that, because ultimately we're concerned about your health. If you decompensate or have an issue and you get sicker, we want to make sure that your response that day, whether it's logged through text or logged through an email response or logged through an automated phone call, we can call you back and talk about your symptoms and see if you need to get triaged to the hospital or you just need to get triaged to get a test. Because if that test turns positive, we obviously want to continue monitoring those symptoms as the bottom of this grid, this graphic shows. This is another slide just taking a look at those social determinants I mentioned earlier and what we call social determinants of health, whether they need neighborhood or environment concerned education or health literacy, or they're unsure about what does COVID-19 mean and what is tracing and tracking and how can we educate. That's another big piece of the puzzle here. And obviously today's effort is to continue to do that for all of you. And I'm hoping you'll educate others as well. One other piece I didn't talk about was behavioral health needs. Being a contact could make someone anxious, right? I was exposed. I don't know who I was exposed to. Will I get sick? What happens if I get sick? There's going to be a lot of questions and anxiety that comes with that. And we want to make sure we connect those people if the anxiety is really uncontrolled or they just need help or they want to talk it through. Beyond talking it through with our nurses in the contact tracing center, we also can create connections to social services and behavioral health services in the county as well. So I think this is actually one of my last slides, and it is giving you some metrics on where we are with contact tracing. I'm looking forward to getting in the questions next, Jonathan. So I'll wrap up with some of these data. We have over 900 now applicants for both the contact tracing jobs, testing jobs that we have, as well as supervisor jobs. We've done, over 90 interviews this week. We've identified several to hire. In conjunction with Lancaster Health Center, the city, WellSpan Ephrata, we have over 40 staff now working on this effort. And this gives you some cumulative results to date over the last week or so. We talked 144 cases and 271 contacts, and only about 42% of the contacts have been contacted. So let's talk about that for a minute and some of my concern there. First off, let's talk about the ratio. We're about a 1 to 2 ratio. So 1 case and about a little bit less than 2 contacts per case. What does that mean? Is that good, bad, or indifferent? Well, the Department of Health is seeing about between 1 and 5 contacts for each positive patient. So that's sort of what our data seems to be jiving with what the nurses across the state are seeing for contact tracing. The concern is, because the literature shows that when everyone's moving around and potentially businesses are back open, the contact numbers can grow from 1 to 5 contacts per case to 5 to 15 contacts per case. So that effectively tripling the amount of outreach we would have to get to potentially as people begin to move around the county. And so that is certainly a concern to us, and we want to be prepared if that increase occurs. But for right now, the other thing I'm concerned about is we're only reaching about 42% of the contacts, either for various reasons. They're not returning our call, they don't understand, they don't know, they're concerned about being a contact and don't want to respond to us. There's a lot of reasons underneath there. Some of those are my hypotheses, obviously, because we never talked to them to know why you didn't call us back. But it's very important for us to spread the word that this is really critical for us to succeed through this pandemic. And even if have a very simple conversation with our contact tracer of, yep, you're a contact, here are your instructions. You need to basically quarantine in your home for this many days and follow up with us daily in case you develop symptoms. It's a simple conversation that then really, after that initial interview, can really be automated, whether it's through a text to your cell phone or an email or an automatic phone call where you're pressing 1 or 2 and responding to symptoms every day. That really gives us the feedback to know, okay, you're not developing symptoms, but if you are, we want to call you as quickly as possible, get you tested as quickly as possible, and make sure any social needs and medical needs are taken care of quickly. So a couple of lessons learned on the right-hand side of the slide. I mentioned about a standard script. We want to make sure that people know, we're from LG Health or we're from Lancaster Health Center. We're calling on, basically out of concern for your health care to make sure that if you get sick, we can hook you up with those medical and social services. We want to continue to engage those contacts with monitoring during the time of their quarantine. Our system that we use to make those phone calls and texts is actually going to be enabled for Spanish this weekend. So we're looking forward to taking both English and Spanish outreach and hopefully future languages to come. Talked about the linkages to social services, but we also strongly believe, and I'm a family physician, so I guess I'm biased, we need to make sure that both the cases and contacts not only are talking to us and the contact tracing team and our team, but also connecting with their primary care provider. It's critically important that we maintain those linkages because this is a really unique effort for all of us as we almost blur the lines between health system, healthcare, and public health authority. And so while we have a foot in both of those banks right now, we're really trying to make sure we ultimately care for those that live and work in Lancaster County. That's all I have, Jonathan. Ready for questions.
Wow, right at 12:45, you are good.
I've been doing this one a while.
Right.
I've been giving this speech for a while.
Excellent. Well, I'll give you a little bit of time to catch your breath there. I appreciate.
That's good. I'll take a glass of water.
Yeah, good. There you go. I appreciate all that information. There's a lot in there. So folks, if you were a little bit maybe late in getting here, on the bottom there's a Q&A function. We've found, I've got 7 questions in there, and then there's some in the chat as well. So please enter them into the question and answer function, and then we can vote on the questions that are in there. Take some time to look through those, and then click the little thumbs up and vote on the ones that you'd like to have answered the most. I have a question myself while folks are looking through there. and that is that there's been a lot of conversation in the county, especially in the newspaper, about creating a county public health department.
Oh, yes.
What is Lancaster General's response to that? Are they supportive? Is this something that you see working in this county, and what benefits could it bring?
Yeah, I think I'll comment on the last piece, Jonathan. Really, through this whole pandemic, we've seen firsthand of the importance of having a structured, timely, coordinated response to public health emergencies, right? That's clear. We need to work together to do that. We've been able to bring a lot of parties together to do that. It's traditionally, these kind of things are accomplished through a county health department, but there are other models we could always consider. The advantage of a public health department, clearly, though, is to include having that formal authority. Think about quarantining in this particular case, that formal authority to respond to health emergencies, access state data, which I know has been contentious early on, but it's gotten better. And it's also, the advantage of a public health authority would be to, bring potential government funding and grants to the county. So there's clearly some advantages to that, but we always should consider other models. In this particular case, we're making it work in the partnership we've created with the Department of Health, the City Board of Health, in an effort to try to make progress on the pandemic.
Excellent. And another quick question from us before we get to some questions from the audience. Do you have data on the age ranges and percentages breakdown for those treated at LGH, as well as maybe race, ethnicity data, and where they're from?
Yeah, sure. I don't have race and ethnicity at my fingertips, but I can tell you I do have a dashboard here on my desktop. Right now, out of all the positive tests that we've done since the beginning, we are at 56% female, 56.5 female, 43.5 male. The average age of those that are positive since we've started is 52.5. And not much difference between males is 53.3 and females 51.9. Let me see, what else can I give you real quick? I could give you the inpatients. Let me have a second for it to refresh itself. I think the inpatient age has been a little bit older. Oh, now of course it timed out. I had it ready to go. Give me 1 second. And I'll get you an update once it runs its course here.
Okay.
See, the inpatients were a little bit older than that average age. Nah, 54.9.
Okay.
So just a little bit older on the inpatients. And then the spread of demographics, I have 16 that are under 1, and I have 3 over 100.
So quite the gamut.
And the spread is mostly pretty even between the 25 and 60 brackets by percent counts. That top percent of that population is running about 8% for each of the 5 years between 25 and 60, between 7 and 8%. And then actually the counts drop off after that, 5% for 65, 5% for 70. And then 4s and 3s for the older folks. So really widespread demographic when you look at all of those that have been tested. I mean, the advantage is a lot of them haven't been admitted overall. I mean, if we're talking about 3,000 plus cases in the county, LG, I just told you, had about 260 admits. So, overall the admissions to hospitals have been lower.
And any information on where in the county those cases are
from?
from?
I wanted to show that. Why don't I share screen one more time?
Sure.
This is actually available publicly on a zip code map, which I think you're seeing now, right, Jonathan?
Yes.
Yeah, so in the Pennsylvania Department of Health, at the header here at the top, you can navigate through their site, and eventually now they just released a beta version that you can get down to the zip code level. And you can take a look at, 17603 had 715 cases. You can flip over 17602 had 713 cases, and 601 had 344 cases. So this is a publicly available data now from the Department of Health to take a look at the zip codes. You can also navigate to certain zip codes on the right here. So hopefully that helps your viewers.
Yep, great.
Yep.
So we'll get to some viewer questions here. The number one question in terms of most votes was from Heather Diggy from the Lancaster Rec. In your opinion, until we have a vaccine and or herd immunity, is it wise to have children in childcare programs in Lancaster County when there are challenges with children wearing masks and keeping the social distance?
Yeah, that's going to be a challenge. We posted on our social media, LG Health social media. I wrote a little blog with our team around childcare, summer camps, and I updated that blog this morning. We put a link to the CDC's website that talks about things to look for facilities. And at this point, that's sort of where I'm advising people to go. Is take a look at the CDC advice. As a parent, it's a very easy site to read, and we left a link on it on our social media site, and you can take a look at that. It is going to be challenging, and I don't, speaking personally about it, it's going to be difficult, I think, for these locations for the very reason you're bringing up. The masking is going to be difficult, and the social distancing are going to be difficult, but getting people into smaller groups is going to be critical, and the CDC article kind of gets into that. So I would make reference to that as well.
Excellent. Thanks for your question, Heather. Stephanie Gromack from Church World Service asked a question, but also I received a comment from Church World Service from Rebecca Garver saying that Church World Service is more than willing to work with you to help with translation, interpretation, education for those groups.
Okay.
So feel free to reach out to them.
That's good. Thank you.
Yep. Stephanie Gromack has a question. It is, could you talk a little about percentage of COVID positive cases within the general community compared to those within nursing facilities as it relates to Lancaster County?
Yes. I'm trying to think of all the stats that I can pull out of my head quickly. Well, you've certainly seen the stats from the coroner, maybe on Lancaster Online, about the deaths. I gave you the stats that 80% of our deaths in the hospital are from skilled nursing facilities. But I counteract that with, that does not mean that this is only affecting those in those facilities, right? I just finished telling you that of the 2,000 plus that we've tested, the age range goes from 0 to 100. So, and a lot of those affected are actually between 20 and 65 for the most count by numbers. It's just, you're not hearing about them because 80% of the people have pretty much mild disease. So others are getting it. It's just, you're hearing more because what is in the news are those stories about the nursing homes. And I would also say of those admitted for us, so this is a little bit different stat, right? I told you of those that died, 80% are from the nursing home, but of those admitted into LGH, only about 40% are from nursing homes. So wow. we have had our fair share. We've had a 19-year-old, a 30-year-old, multiple 30-year-olds, people in their mid-40s, definitely admitted, definitely ill, definitely intubated. So yeah, we've definitely, from a hospitalization perspective, have seen the age gamut in the same way that the 2,000 plus results that LG Health has is affecting all the ages. We're seeing the same in terms of overall admissions. Hope that helps. I don't have every stat at my fingertips, but that's the relative answer.
Okay, great. Thank you, Stephanie. Chris Metzler asks, how has the medical community accounted for, if at all, the impact of colleges opening on Lancaster County medical services? I would assume that this is for the fall.
Yeah. Hard to predict how colleges, the same way it's hard to predict how businesses are going to affect this. And that's why if I didn't say it enough, I'll say it over and over again. All of us need to practice social distancing, wear masks, practice hand hygiene, wash your hands, because those are the things that no matter what color we're in, no matter what's open, and no matter where people go, that's what we got to be doing before vaccination for sure.
Thanks, Chris. Lauren Riley asks, how do COVID-19 infection numbers compare to this year's common flu infection numbers?
They're higher, and I don't have those, Lauren, off the tip of my finger, but if you Google the Department of Health and flu cases, you can Google Pennsylvania Department of Health flu cases. You can compare last year's numbers And then I just gave you some numbers right now for Lancaster County for COVID. So it's worse. I mean, the overall deaths are worse. I can't quote you exactly what they are off the top of my head. But it's easy to find them. You should be able to Google it pretty easily.
Tom Gemmel asks, what COVID patients get managed at home? How many of the people in that home then get infected? Why do we not have an isolation facility for infected persons?
Okay, so I think the general gist of that beginning of that question was, I'll refer you back to one of my early slides where I said only about 10% of household contacts are getting it. And that's primarily because if you really practice good isolation measures in your house, you know, if you get it, you got to go to a room, you got to limit the bathroom's use, you got to use frequent surface cleanings, Clorox wipes, etc. That really reduces the potential risk. Now, granted, think about like influenza. People are so sick, they don't want to move around anyway. So the chances of you spreading it, if you practice sort of these almost the social distancing and prevention measures at home, you're more likely to reduce the spread. And I can't answer why we don't have an isolation facility.
Kevin Ditzler from United Way, no, WITF now, sorry, Kevin. He says, would it be better to see a surge in the summer, spreading from flu season, separating it from flu season, or continuing to wait and risk too much overwhelming the health system in the fall?
We worry about the overwhelming of the health system in the fall, but I will say this, if we get really good at the infection control measures, we'll actually have less flu, right? Because how does flu spread? It spreads in the same way. So regardless of whether it spikes in the summer or spikes in the fall, I think we're living with COVID for a long time, just like we've seen even the inpatient census has gone on in the mid-40s for us for quite a number of weeks without showing signs of letting up. So whether it eventually gets a little bit lower and then comes back, ultimately the same guidance remains.
So I've got a question that I think a lot of folks are asking in general is, have we overreacted to this disease? Have our measures that we've been put in place been more than adequate?
Yeah, so it's hard to always, this is the Monday morning quarterback question that everybody asks, right? I'm going to give you my family physician answer on this one, and public health answer. Looking at other areas in the country where it spread so rapidly, so quickly, I would like to think that we did not overreact. We did the right things. We put the right public health measures in place. And as a result of that, we had containment. And I look at this more optimistically, maybe than others, but that's my quick answer for that, Jonathan. I'm looking at time, and I'm not sure where else you want to go.
Left, so I think I'm going to wrap up there, and appreciate all of these questions. Like I said, we will be putting this on YouTube. I want to take a quick moment to thank Dr. Ripchinski for taking time and for his leadership during this COVID crisis. We appreciate it. Thank you.
No problem. Thank you. Have a nice day.
And then again, to thank our sponsors, Rogers & Associates and Millersville University. We appreciate the support. Without them, it would be tough to put these forums on. So we appreciate that. And in addition, next month in July, we typically don't have a forum, but because of COVID and the way things have worked out with these webinar forums, we're going to host one. So the topic will be very relevant. I'm not going to release it yet because we're still ironing out some details, but we're very excited about it. And it's something that I'm sure you all will want to come back for. So thanks so much for joining us, and make sure to stay safe and practice the social distancing that we talked about today. One last question. If I need a mask in a jiffy, can I use my terrible towel? Does that work?
That's good.
Okay, good. Wonderful. Well, thank you, everybody, and have a wonderful weekend.
Bye-bye.